To talk about a little about epidemiology and mostly about treatment for anorexia and bulimia nervosa. And so, the way we categorize these illnesses by DSM, now DSM-5. So very simplistically, people with anorexia lose a lot of weight, and they don't eat very much. People with bulimia nervosa tend to overeat, and followed by some kind of compensatory behavior, usually purging behaviors. And these are both groups that have body image distortions. They tend to be mostly female. Just want to make the point very simplistically that while the DSM categorizes people into anorexia and bulimia, it's actually more common that people have an NOS, not otherwise specified diagnosis. Now in DSM-5, it's called other specified eating disorders or feeding eating disorders. These are people that often don't quite meet criteria for anorexia or bulimia, but they're just as ill. But it also includes other categories like binge eating disorder. A little about prevalence. So this is a one-year prevalence rate per 100,000 females. I want to make a couple of points here. As you can see, bulimia is much more common than anorexia nervosa in the community. And one of the things that we have about this illness is that relatively few people actually end up in mental health care. And when they do, even though anorexia is less common, it's the more common disorder that's treated by the mental health system, and I'll tell you a little bit about why that is. To put it in another perspective, in the field, we kind of use the numbers that roughly about 1% of women will have a lifetime prevalence of anorexia, and if you use a broad category for bulimia, it could be as much as 3 to 5%. But those are, it's hard to get really solid figures. So these are, people have an onset during adolescence. Why is this such a hard disorder to treat? It's not just that they have pathologic eating, but it's actually that they don't want treatment. Particularly the anorexics have a lot of denial, they lack insight, they're resistant and at best ambivalent about treatment. One of the things that's become apparent in the last decade or so is that there's a very powerful biology that's really driving these disorders, and that this is not just mere psychosocial kind of response to culture or stress, but there's actually an underlying powerful neurobiology here. What happens to these people? Well, over the course of time, a majority of them get better, but often they're ill for 5 or 10 years before they recover, and even with that, 30% remain chronically ill, and as many as 10% of them will die from this illness. Probably the most common psychiatric, high psychiatric death rate. So we provide treatment in a wide variety of settings, not surprising to you, everything from outpatient to inpatient psychiatric facilities or residential kinds of programs. Most people with bulimia are treated as outpatients, so that they're treated with medication, there's some proven psychotherapies like cognitive behavioral therapies or more dynamic psychotherapies. And the bottom line is that most people have some degree of getting better, but actually relatively few become abstinents. There's a percent that really don't respond very well to treatment. They tend to be more behaviorally dysregulated and have mood and substance abuse problems. It's probably 25% or so, and those are the people that end up in higher levels of care most likely, especially as they get older as adults. What about anorexics? These are the people that tend to form somewhat of a majority probably of treatment in this country, and they often need higher levels of care because they're malnourished, they need to have weight restored, they're at a high rate of dying, risk of dying because of medical complications, just starving themselves to death, and most importantly, again, you have to force them to get treatment because of resistance and denial and lack of insight. Now, we have no proven treatments that cure or reverse anorexia nervosa. And it takes a long time. At the very best, you might be able to get people to gain 3 pounds a week in an inpatient setting. But if you're down 30 pounds, that's 2 or 3 months of treatment right there, and it's usually much longer than that. And there's a very high rate of relapse. As many as 75% of these people relapse after they're in a course of treatment, especially during adolescence. So what do we do about treatment? Well, there's only one treatment for adolescents with anorexia that's actually been shown to have some efficacy, and that's a treatment that's called Maudsley or family-based treatment. And what's different about this treatment is we align with the families, and we teach the families how to understand and manage this disorder, because this is a chronic disorder. It's going to go on for years. But even with this treatment, it's certainly not a cure. Roughly about 50% have a good outcome at the end of 1 year. So that still leaves a lot of kids that aren't responding. And one of the limitations of this treatment, there are very few people that are actually trained in this treatment in this country. The other thing that happens to these people is they end up in short-term kinds of medical or psychiatric hospitalizations where their medical condition their medical instability is stabilized, and they're refed to some degree, and then they're discharged. So it looks like actually a majority of the treatment now that's being delivered in this country is being delivered either in residential or psychiatric inpatient kinds of treatment. The people that are really at low weight and need to be need to be weight restored. And it's controversial what is a healthy, getting people up to healthy body weight is now very difficult because of insurance limitations, and often insurance companies force you to discharge people when they're 75, 85% body weight. A lot of the treatment is being delivered in residential treatment programs, which is a growing and variable and really highly unregulated enterprise. There's a range of therapeutic marketing approaches. There's no proven treatments. These programs tend to have very attractive kind of spa-like settings, great marketing, but once you get in the door, it's not really clear what any one program is doing because there is no outcome data, and they tend to have a wide variety of staff. Of course, some are very good programs, but also many of them really have, employ part-time kind of people and people with very little training. There's very little data on residential treatment programs. This is the only paper I could really find in the literature which was from 2006 that looked at 22 residential eating disorder treatment programs with a wide range of licenses. Few of them had JCO accreditation. At this point, which was almost 10 years ago, they had very long lengths of stay, 83 days, with an average cost of about $1,000 a day. So you're talking about $80,000 to treat these people, and often this is paid out of pocket because this is not necessarily something the insurance companies will support, at least this long length of stay. And in the last, as of 2004, there had been a large expansion, and actually there's a really large expansion ongoing now. Many of the residential programs, which are small residential programs or mom and pop kind of shops, have now been bought up by various private equity investment groups in eating disorders. Just to list this probably isn't even up to date, and this is from last year, of all the different private equity funds that are now running residential treatment programs. So one of the things that we've done at UCSD is really kind of ask the question is how can we provide effective, cheaper but effective treatments for people with anorexia nervosa. We've based this really on Maudsley family-based kinds of treatment because of the fact that there's evidence that this is effective, at least for a group of people, and we actually have done some outcome studies showing that we can deliver an efficacious kind of treatment. We also have an adult dysregulated behavioral program based more on dialectic behavioral therapy. This has been a very rapid growth program that we've actually increased our business 20 to 40% every year since 2009. We're now the largest provider, single site provider in California. What we do is we do a continuum of care model where people can stay anywhere from 10 hours a day, 6 days a week, down to 3 hours a day, 3 days a week, so that working with insurance companies, they like to see this continuum of care where we can bounce people up and down the continuum depending on what their needs are. One of the nice things about this, you can do it in an office building. You don't need the overhead of 24-hour nursing staff as you do in residential. And one of the things that we've found is that relatively few people actually need residential program. It's probably only about 10% that really need this higher level of care. But really what makes this program work and makes it really effective is that we really have a highly experienced trained staff where we spent a lot of time, about 6 to 8 hours a week for each staff member in supervision and training, so that they actually have a high level of expertise. We manage both the staff and the patient's and family's temperament, which is really very important in understanding how to kind of work with these people. And we have outcome protocols, and this is very much integrated with our research. As we're beginning to understand more about the biology of these disorders, we're finding that we can deliver more effective treatments aimed at their temperament. Limitations, the big thing is that you have to live fairly close to one of these centers within an hour, and it's useful for some families, but there are other families that is really too stressful. So thanks very much.